We're back in the plenary studio after the morning coffee break for a session on polypectomy. So this session is directed at all types of lower GI lesions, best endoscopic practice, and we're trying to separate out what the differences are in technique and options between the rectum and the rest of the colon. This is a 2-hour session which the objectives are to understand the unique challenges of rectal lesions and what the differences are between those and colonic lesions, evaluate the role of EMR, ESD in full thickness resection in the management of rectal lesions, think about advanced techniques for resection of lesions in complex locations like the appendix and ICV, explore decision-making processes for choosing between en-bloc and piecemeal resection, and gain insights into resecting lesions at anatomically challenging sites.
First of all, I want to thank Dr. Tate and all the GIEQs organizing committee for giving me the opportunity to present this lecture entitled Understanding the Rectum as a Separate Organ. So we know that rectal lesions are challenging often, and understanding the basics is really key to optimize then the treatment. We will discuss the challenging in the management of rectal lesions and the importance that local resection techniques have for organ preservation. So, starting with the basics. The rectum is a 15 centimeter long organ which has unique anatomical features compared to the colon. So it lacks the taenia, the haustre, and it has 3 transverse folds, also known as Houston valves. These are the superior, the mid, and the inferior, and they are key anatomical landmarks when describing rectal lesions, and we will see some examples later. The rectum has a different relationship with the peritoneum based on the location. So the superior third of the rectum is covered anteriorly and laterally by the peritoneum, so it is intraperitoneal largely. Whether the middle third is covered just in the anterior wall, and the inferior rectum is totally extraperitoneal, so it is much safer. Of course, photo and possibly video documentation for referral are essential. So we also often send these lesions for a local staging with MRI, for example, and these cross-sectional imaging techniques can help us a lot to also localize the lesion. Let's see some examples. This lesion is around 4 centimeters from the anal verge. We can see the inferior Houston valve, so it is located below the inferior Houston valve. We know that this lesion is in the inferior rectum, and this picture is actually, I think, beautiful for an interventional endoscopist for referral. We know that it's taken from close to the anal verge. It is framing the Houston valves. There is water. We know that the patient is on the left lateral, so this lesion is on the left lateral wall, and we can say that the right lateral wall is the contralateral, and then we can infer the posterior and the anterior from this. This is another example, lesion more proximal. It is here. This is the left, again, patient on the left lateral wall. This is the right, so this lesion is located 11 centimeters from the anal verge, above the mid-Houston valve, and it is located on the left anterior rectal wall. This video shows another lesion. This is a pull back in forward view. We will see a lesion in a while. So superior Houston valve with maximal insufflation, mid-Houston valve, inferior, and that's the lesion. It was previously biopsied, so it is bleeding, but that's just to show how to localize the lesion. Same lesion. This is the water, patient in left lateral. Easy to say, it is located on the right wall, right posterior if we may, but that's the concept. Same lesion. How to assess it on retroflexion. This is a very beautiful image. Also, I think important for referral. And we can, it is not always possible, but we can try, I think, for detection and characterization to inspect the mid and the proximal rectum in retroflexion. You need a scope with a good bending. You need to be gentle, to do a 360 rotation and gently push your scope. And you can detect something it was not obviously seen in forward view in the.
And this is a talk I've often wanted to give some, I hope you don't mind, about why we're moving on from EMR and what the reasons are in the rectum. Thanks, Brian.
Great. So, yeah, it's an interesting title. So EMR for rectal lesions, are we moving beyond it? And I think this sort of follows on from what we've seen already today. So EMR, you know, we love EMR. It's a great technique. If it's done well, it's very good, and it's quick and it's relatively simple. We work sequentially across the polyp, taking reasonable sized pieces, nice clean base, being careful to take the edge, and then diathermy around the edges. And with that, with good technique, and you can use argon plasma coagulation or snare-tip soft coagulation, and in particular looking at the intersections and burning any additional prominent submucosa, you can get recurrence rates down to 5%. So why do we need to do anything different? Well, there are still problems with piecemeal EMR, and illustrated by this slide showing all these multiple polyp pieces. The first is we don't have an R0 resection, so we have to do an early check. So that means another bowel preparation for the patient. The histology is incomplete, and if there is a small focus of cancer within the polyp, which does happen, then the patient may end up getting unnecessary surgery. And surgery in the proximal colon is not perhaps such an issue, because with robotic surgery it's more straightforward. But in the rectum, it's a major problem. Transabdominal access to the pelvis is difficult. Patients may end up with a temporary or permanent stoma, which is a major issue for the patient. There is a mortality associated with that surgery, particularly in our older comorbid patients. And the functional outcomes after surgery are not always good. In fact, studies show that the low anterior resection syndrome, where they're getting major functional symptoms, occurs in about 63% with a low anterior resection from the rectum. So the rectum is fundamentally different to the colon. And in the rectum, we want ideally to do an en bloc excision. Also, we know that the risk of occult submucosal cancer in patients referred for an endoscopic resection is significantly higher, possibly twice as high in the distal colon compared to the proximal colon. And for us as endoscopists, access into the rectum is really easy. It's a direct access. The submucosal layer is relatively thick, so that there's a margin for error in terms of perforation. And even if we do need to go into the muscle layer or full thickness, as you can see here, it's really not such an issue. So in the rectum, there is a clear trend and important switch towards en bloc excision with ESD rather than piecemeal EMR. Of course, all of these decisions need to be very, very carefully thought out and worked out prior to the actual resection. And we're all familiar, unfortunately, from 2020 with PPE, but this is the new PPEE. Think about the patient, the polyp, the endoscopist, the environment. Getting all of these things right leads to a successful resection. And I would also emphasize that safety and simplicity always trumps complexity and technical perfection. So we have to weigh up all of these things. We might have a very elderly comorbid patient who can have a 20-minute piecemeal EMR, which is a better procedure than a lengthy deep sedation ESD. This is using the new ultra slim speedboat, which finally the speedboat is down to a size whereby it's very practical, can be used through a gastroscope or a pediatric colonoscope. And this has novel properties in that we're using radiofrequency cutting and then microwave coagulation. There's microwave coagulation for a small vessel. And then later we've got a larger vessel here, which we can microwave and then cut. And the advantage with this device is we're not needing to do instrument exchanges. Now, the microwave is very effective even for larger rectal vessels. And we can microwave, coagulate, and then cut without needing to pause. A lot of the time implication with ESD, and the reason that ESD takes a long time, is the need for instrument exchange, and minimizing that is really crucial. So here's the final cut, just taking this lesion off.